So one of my most memorable patients with mantle cell is a woman who had been through lots of therapies, was basically on her way to hospice, and doing quite poorly. I vividly remember being in the hospital with her, and as a last-ditch thing, we put her on the pivotal trial of ibrutinib, and she had a beautiful response, and we did an allotransplant in her, and she's now 5 years out, doing great. So the question is, what is the role, and that's just obviously an extreme example, but we're not expecting that these drugs are curing patients. Certainly there are long-term remissions with ibrutinib and most likely with acalabrutinib as well. You know, when are you going to do an auto transplant? And if you've got particularly a young patient, but it could be an older patient too, who's doing well on one of these therapies, you get them into a second or third CR. Clearly you have to talk to them about allotransplant. I know, no doubt you're also talking about CAR T cells, but where does allotransplant fit today in this scenario?
I mean, I think there is a place for it.
Yeah.
And I think auto transplant is only in first remission to get a nice long PFS. The relapsed patients, as I alluded to before, you know, occasionally the disease is the same that they presented with, but in general, relapsed mantle cell lymphoma is ominous. It tends to be more aggressive when it relapses. It's not like relapsed follicular lymphoma, where you can count on another long remission to second-line therapy. So I tend to be more aggressive with this disease, and for example, I agree with Andre, everybody gets rebiopsy because you need to know what the mutation status is. That tells you how much mileage you get out of chemotherapy and how much you can rely on, you know, kinase inhibition or BCL2 inhibition to get them into a remission. But those remissions or disease control states are only transient. And like in your patient, I think they're the ones that I would consider doing, if they're candidates, allotransplant on right now. Hopefully in the future, CAR T cell or something easier. And you know I'm not the biggest fan of allotransplant.
Today's day, the only way we can cure the patient in relapse setting is an allotransplant, mini allo or haplo. And some of these patients have a very, very prolonged, higher patients who are 15 years out of mini allo and doing well.
But you wouldn't do it in first remission, Andre, correct?
I would not do it in first remission. With
unless
a really
it was
rare exception. I had
like
some very aggressive
mutations.
blastoid and all that variant with extensive disease having a lazy response from induction. Then I would do that, otherwise no.